Hello. Hello.
Yes, sir, you're audible now.
Okay, fine. Thank you. See the stage now. Hello. Is there anyone?
Yes, sir, slides are visible.
Okay, thank you. Uh, if everything is in the means, you can text me.
Yes, sir.
Uh, so today's topic is on the types of lower limb amputation. Right. So basic is what is an amputation. Amputation is removal of either a part or the whole of the limb. Okay, for a cause it may be for a surgery because the surgery may be due to the ischemia caused by the trauma or the infection or any tumor. Depends on the site we will go for which type of amputation we are doing. Okay, the main indications are for the amputation are trauma followed by the vascular pathologies, that is the ischemia, the thrombus blocking the femoral vein or popliteal vein, or the arteries which will leads to acute ischemia, acute critical limb ischemia. Right. Other than that, the most common cases that are indicated for the amputation are diabetic foods. Diabetic food with an ascending infection, which is non-controlled by insulin and others. Right. So basically, we do amputation as a surgical measure to alleviate the pain and other symptoms, or to restore the limb function by the prosthesis which we give to the patient after the surgery, after amputation. Okay. These are the indications. The indication is primarily the diabetic mellitus, which leads to diabetic foot syndrome with ascending infection, which is uncontrolled after multiple debridements, which will no other way we are going for amputation. And the vascular diseases, as I already told, that is nothing but the acute limb ischemia due to the thrombus in femoral artery or some other artery regarding the lower limb. And the next one is trauma. And the tumors mainly malignant melanoma, sarcoma, and other musculoskeletal tumor, osteosarcoma, kind of things which lead amputation with the joint above. Okay, then other infection, neurological disease, and congenital problems. Entering into types of amputation on the lower limb itself uh, is divided into open and closed. The open and closed, the name mention how the wound is left after the amputation. If it is open, means it is otherwise it is mostly done and it is otherwise called as guillotine amputation. Other one is closed. So open amputation or guillotine amputation. When will we do this? In case of any emergency setting, we will be going for open amputation only. Because in case of an emergency, if we are doing as an emergency, means the patient is not prepared for the surgery, first of all. Secondly, there will be infection. As in case of trauma or infective disease or thrombosis, which will leading to amputation at the end, will have a infective foci or pus inside, which we cannot close with that infective foci. If we close, means it will surely lead to ascending infection again. Okay. So in that open amputation, we are having two types. One is open with inverted skin flap, and the other is circular open amputation. Open with inverted skin flap is nothing but we leave a flap of skin with the muscle in the posterior or anterior aspect or anterior aspect, either one side, which we will use for the closure of the wound in the forthcoming days when the wound is healthy after multiple debridement without any slough and without any organism and repeat cultures, pus cultures. Okay. And the other one is circular amputation. Regarding dressing, if we do an open amputation, there should be two dressings. First one is soft dressing, which we usually do for any other cases or any clean cases or any elective procedures. We do a soft dressing, which is with a gauze and pad roll, and we applied an elastic bandage. The main thing regarding amputation is we do a rigid dressing. Rigid dressing is nothing but that's applying of POP over a soft dressing. POP is the plaster of Paris that you people know, with the calcium and the lime. Its main duty is to immobilize the amputated limb. With what we aim is that if we are doing a below knee amputation, for example, if we are doing a below knee amputation means there will be flexors and the extensors in the thigh. Okay, after BK amputation, the flexors of the flexors will overact, leading to the flexion contracture and flexion deformity of that limb. So to counteract that, we are putting a POP, plaster of Paris, with the knee kept in completely extended position. Are you people hearing?
Yes,
Hello.
sir.
Is it legible? Is it understandable, or I have to slow down?
I didn't understand the open with inverted skin flap and circular open amputation, sir.
It's okay. I will tell you. Open with inverted skin flap means if we are doing amputation means we will leave a flap. You people aware of the flap? Okay, let me tell you. See in that here you have a flap, right? The bone is amputated, the muscle is amputated. You have a flap in the posterior aspect which is hanging down. Hello.
Yes, sir.
This is nothing but the inverted skin flap, which will be used for the closure in forthcoming days when the wound is very healthy without any culture organism or without any slough.
Okay, sir.
Right. We will just tag this flap which is hanging down to the upper border. I mean the anterior margin of the wound.
Okay,
Can you
sir.
understand?
Yes, sir.
That is inverted skin flap, and the other one is which we don't leave any flap. We have no healthy tissue to leave as a flap. That much bad the wound is, so we have to amputate as a circular open wound. We can't do anything for that. Okay, it should heal on itself. And regarding dressings, it is okay, va? Soft dressing and rigid dressing. Rigid dressing is most
Yes, sir.
important for the plaster with the plaster of Paris, which is to prevent mainly the flexion deformity or flexion contracture. In case of BK or other cases, regarding the type of amputation, the POP should be kept in a particular position. The next one is a closed amputation, which means which is nothing but we are doing an amputation and we are closing the wound. We are not leaving the wound open. This is mostly done as an elective procedure, which is indicated mostly for the tumor. That is the main thing. For an osteosarcoma or any other bone tumor or sarcoma, soft tissue sarcoma, or in case of melanoma or something, we can do an amputation one joint above and we will close the wound. Okay. In case of closure, we can do two things. Anyhow, we are having an anterior aspect and posterior aspect of muscle for any case of amputation. Right. If we are doing an amputation means we should cut the bone 4 to 5 centimeters above the skin incision or where you are leaving the muscle. That is where you have to amputate. For what means the bone should not be exposed or bone should not be pricking the skin surface which you are closing. The bone will be 4 to 5 centimeters proximal when compared to the muscle where you cut in case of amputation. The remaining muscle, both the anterior and posterior aspect will be sutured. If they are suturing a muscle to a muscle from anterior to posterior, it is called myoplasty. If you are suturing a muscle to a periosteum of the bone, it is called myodesis. Right? Hello?
Yes, sir.
You people understand or not? If you people want to repeat me means I will repeat. Hello?
Understood, sir.
Okay. The basics of amputation is nothing but the muscle is divided at least 5 centimeters distal for the flap, for the coverage, right? And the muscle is resected 5 centimeters distal, which means we are leaving the more healthy muscle distally to cover the wound, to suture it and close the wound. The bone section should be above the level of muscle section, and the nerves. This is the most important thing. The nerve should be cut proximal. You cannot explore in the wound proximal the nerve. What you should do means the nerve should be pulled up from the wound, right? You should identify the nerve. You should pull the nerve. You should pull the nerve out. You should cut the nerve after pulling out, which means when you leave the nerve after cutting, it will run away inside. It will run away most proximally. For what we are doing this means, if we cut the nerve at the level of wound itself, it will cause post-operative neuralgia. Hello.
Yes, sir.
It will cause mostly the post-op neuralgia, which is the most uh, considering thing for a surgeon or for a patient. They will complain of pain all the time if you cut the nerve at the surface of the wound. For that purpose, you should pull the nerve out, cut it, and if you, at once you leave, the nerve should go inside the wound without the nerve fibers at the surface, which will go for irritation if it is at the surface. Then the blood vessels should be doubly ligated and cut, and the drain is kept for the reactive collection, reactive fluid. Any surgery, anywhere you do, there will be reactive fluid from the surface of the wound. For that purpose, we are keeping the drain. Then the compression dress is to be done, and the absolute bed rest with limb elevation to prevent the edema. Then the ultimate thing regarding an amputation is you should aim for a prosthesis. Right, prosthesis is nothing but the artificial limb. Right, conventional prosthesis will be given at the second or third month of surgery. When the wound heals completely, you can fit a prosthesis, and he or she, whoever the patient is, you can lead a healthy life as before. Right. There are many processes available for below knee amputation, above knee amputation, and even for a hip amputation, trans hip. Then hip disarticulation. I am coming from above to downwards, from hip to toe. Right. Hip disarticulation. Hip disarticulation. There is two things. One is disarticulation, and another one is the amputation. Both have difference. Anyone knows the difference between the disarticulation and the amputation? Hello. Hello. Hello.
Yes, sir.
Now audible?
Yes, sir. You're audible.
No. Can anyone between disarticulation and an amputation? The disarticulation is nothing but we are opening the joint, and we are just cutting the ligaments, and we are making the bone to fall apart. That's there is nothing regarding cutting the bones. Right. If you are doing a knee amputation, means you are opening the knee joint and making the femur, tibia, and fibula, everything separate. You are making it fall away. You are separating the tibia and fibula from the femur. That is knee disarticulation. Okay.
Yes, sir. Only ligaments are cut through, sir.
The ligaments are cut, and you are not injuring any bone. The bones are as such it is. You are just disarticulating. You are what if it is suppose it is a shoulder joint, means you are cutting the Glenon's capsule and glenohumeral ligaments and everything, and you are taking that humerus out with the head uninjured. Everything will be the same structure, but the joint will be open and cut off. Okay. In case of amputation, you will cut the bone surface itself. So the bone structure will be altered. Understood?
Yes, sir.
If you are not understanding, means you just tell me. I will explain it different way.
Understood, sir.
So the hip disarticulation is nothing but if you pluck the head of the femur outside of that socket in the hip. This is nothing but the hip disarticulation. Okay. So the hip disarticulation is surgical removal of the entire lower limb by transition to the hip joint. The causes of we already know, as I said, it can be done for a trauma, ischemia, trauma, other severe infections and the tumors. The levels of disarticulations are different in case of hip. There is a true hip disarticulation, there is a modified hip disarticulation, and the transfer weak amputation. The levels of disarticulation in the modified hip uh, taking the femur out at the neck of the femur. In case of true hip disarticulation, which is nothing but what I said as a disarticulation, in which the head of the femur is taken out. Okay. In case of transpelvic amputation or hemipelvectomy, which is done in two ways. One is internal hemipelvectomy, and another is external hemipelvectomy, which I will show now. Hemipelvectomy, which is in case of internal hemipelvectomy, a portion of the pelvis is removed, which can be ischium, or it can be ilium, or it can be the ramus, anything.
இல்ல
A part.
சரி எதுக்கு
Hello.
அதான் விளையாடிட்டு இருக்கேன்.
அது சார்ஜ் ஏறாதுடா சைடுல
Hello.
ஸ்கிரீன்
அதெல்லாம் ஏறும்டா.
டேய் ஏறாதுடா
இரு எவ்வளவு இருக்கு சார்ஜ்?
Hello.
Yes,
Okay.
you can continue, sir.
So, okay, internal hemipelvectomy. Internal hemipelvectomy is only a portion of the pelvis is removed, and the ipsilateral limb is spared, which is nothing but I shown here. This limb is here. This limb is here, which is intact. We will remove a part of this. This is hemipelvectomy. This is pelvis, and we are removing a part of this, which is nothing but a hemipelvectomy. In case of internal hemipelvectomy, we will do either type 1, type 2, or type 3. Right. Hemipelvectomy, in which the pelvis plus the ipsilateral limb is removed, which is known as the hindquarter amputation. Right. This limb will be removed. Along with this, we will remove this part, or this part, or this part. Regarding the disease, the next one coming down from the hip is above knee amputation. Above knee amputation, ideal stump length, which is nothing but from the greater trochanter. The length should be measured from the greater trochanter. From there, you should leave a stump length of 25 to 30 centimeters. Why it is called ideal stump length means the two things are considered. The very important thing is regarding prosthesis. The very long stump, the remaining stump you leave. If it is very long or if it is very short, it will affect the prosthesis. It should be an ideal stump length. 25 to 30 centimeters means if you are leaving only 18 centimeters means we have to alter the processes according to this firstly, and the movements will not be that much good as it is before. Right. So the 25 to 30 centimeters from the greater trochanter is the ideal length, the ideal stump length for an AK amputation. If you leave this ideal stump length, the function will be good and the processes can fit in perfectly. These two things are very important. And one more thing more important is regarding the healing. Shorter the stump you leave, the faster will be the healing. The more the length you leave the stump, the healing will be less. So it is it is just opposite to the processes. If you leave the stump length more means the processes will fit good, but the healing will be late. If you leave the stump length short means the processes will be difficult, but the healing will be good. Okay, so the ideal stump length is very important from 25 to 30 centimeters from the greater trochanter. Then, as I said before, the bone should be cut above. Then the muscles should be left 5 centimeters from the level of where you transect bone, and the incision deep. This is nothing but the process. Equal anterior and posterior flaps should be left, and the bone should be cut above. Incision deep into the deep fascia, anterior muscles divided. Femoral vessels mostly see where will you find now below the sartorius, from the in the femoral canal. Right. Femoral vessels, nerves, everything. And the femoral nerve, as I said, it is gently pulled down and ligated and then cut and allowed it to retract into the wound. Then the femur is cutted with using jiggly saw, which is steel-like instrument, which will look like a spring. Other than the femoral artery, we should search for profunda femoris, and also we should doubly like it. Then the sciatic nerve, which is more important in above knee amputation. The sciatic nerve should be identified, which is mostly identified in the posterior aspect, and it should be pulled down, ligated, cut, and allowed to retract. Then the posterior group of muscles are divided. Then the limb is removed, hemostasis is achieved, and the myodesis. Here, myodesis is given. Myodesis means, as I said, the muscle is sutured to periosteum. We can do either myodesis or myoplasty, both. Regarding the situation, if the anterior group of muscle is healthy, means we can do myoplasty. If it is not healthy, means we go for myodesis. Okay. This is what AK amputation picture. See, this is the femur V that is cut, and we are making the incision like a fish mouth. This is seeming like a fish mouth, right? If you consider fish cut means this should be fish mouth. It should be opening and closing. Fish mouth incision is used in case of above knee amputation. Okay, wow. Both the lip of the fish mouth is nothing but the anterior and the posterior top. And the bone will be cut twice and proximally, and the muscle will be protruding from the wound, which will be used for myoplasty or myodesis. In the soft tissue, then the skin will be closed. And the post-operatively, the wound will be like this. Post-operatively, the wound will be like this. This is a closed amputation. If we do an open amputation, the wound will be like this only. It will be open like this. After we get a healthy tissue over the anterior flap and the posterior flap, we will close this like this. Then, as I said, it is a knee disarticulation, badge, splitter, and McFadden technique. There are three techniques. This is the first technique, badge, splitter, and McFadden technique, in which anterior flap is left very long, which will be used to close the wound at the last. Okay, flap is long and popliteal vessels are ligated and tight, and the tibial nerve is also ligated and tight. Then the main thing is we are dividing the cruciate ligaments. There are two cruciate ligaments, as you know, anterior and posterior cruciate ligaments. And posterior capsule is divided. The main thing is the patella. The inferior polar patella will be raised along with the anterior flap, which means the cartilage will be coming in front of the patella and inserting into the tibia. Right. We are cutting that. We are entering the knee joint. We are taking the patella anteriorly as an anterior flap with the skin and subcutaneous tissue over there. Okay, which will be used to close the wound. The patella will be sutured to the femoral condyle. That is how we close this knee disarticulation wound. Okay, and the patellar tendon will be closer to the cruciate ligament which we divided. The second technique is Masseton-Hennessy disarticulation. It is nothing but the debulking. The same way we are removing the tibia and femora from the knee joint, that is the femur and patella. From the femur and patella, we are removing the tibia and fibula, this is the basic of the knee disarticulation. Masseton-Hennessy disarticulation, in which debulking stump is removed by resecting the medial, lateral, and posterior surface of the femoral condyles. Okay, so we are removing a we are removing medial, lateral, and posterior aspect, and the anterior aspect we are leaving it as I told before, which will be used for the closing. And the third thing, which is the jawbone disarticulation, here we are raising instead of anterior, medial and the lateral flaps. Right. So other than that, every procedure will be same. below knee amputation. Below knee amputation ideal strength is 15 centimeter and the ideal stump length, the importance as I said before, the process is under the healing. Anterior flap is cut at the level of bone division and the posterior flap which is made and below knee amputation the specification is more important. 1.5 times the diameter of the leg. This is what you leave the posterior length. Usually from the tibia you will measure 15 centimeters in the leg. There you will mark an incision and that point you will make a circumference. You will measure the circumference. Okay, that is the diameter of the leg. If the diameter is 10 centimeter, you should leave 15 centimeter flap in the posterior aspect. That is what here said, the posterior flap made long 1.5 times the diameter of the leg. Then the vessels are doubly ligated and cut, nerves and pulled, cut and retracted. Then the tibia is cut with the giclisa followed by fibula. Here there are two bones, tibia and fibula. In this case of below knee amputation, the fibula should be transected 1 centimeter above the tibia. This is tibia. This is tibia. Tibial stump with the bone marrow exposed. The fibula will be here, which is not seen. This is the posterior muscle with the flap left more than 1.5 times the diameter of the leg. Okay. Then coming to foot amputation, there will be in case of foot amputation, there are amputation, toe disarticulation, and transmetatarsal amputation, raise amputation. This foot will come from distal to proximal. Right. Before and so-called disarticulation, in hindfoot they have barograms. Distal to proximal. What is the most distal bony structures in any limb? That will be upper limb or lower limb. In case of lower limb in a foot, you will be having a terminal phalanges, distal phalanges in any toes. Okay. If you are encountering a patient with a wound or with a gangrene in a distal phalanges only, the other part of the phalanges, which is the proximal and the middle phalanges, are healthy. You when you see clinically and when you see in the X-rays, what you will go for means you will go for a terminal sign amputation, which is nothing but the removing only the distal phalanges, distal phalanx of the finger. That is preserving the insertion of the flexor and extensor hallucis longus. This is the most important concept regarding that. So the movement will be preserved. Both flexion and extension, the movement will be preserved. Only the distal half of the distal phalanx will be removed. This is only for the cases with very distal wounds. Like here, we are having a wound in the tip only. So we go for a terminal signs amputation and we close here. Right. The next one is raise amputation. The raise amputation is the most common type of amputation we are doing nowadays. Right. Which is amputation of a toe with its metatarsal head. The question here is why we are removing that metatarsal head. We are doing the raise amputation mainly for removing the toe. Okay, the toe will be gangrene, the toe will have a wet gangrene or dry gangrene, or it may be a trauma. Why we are removing the metatarsal head? Because there is a scientific study which shows that proliferating factors will come from proliferating, and the proliferating factors mainly come from the bone marrow. Okay. Hello. Hello.
Couldn't understand the last part, sir.
Last one means
The good healing part.
good. I can't get you. Which one?
So you're saying about the proliferative factors in good healing.
Okay. The raise amputation. Raise amputation is mainly amputation of toe. Okay, but we are not stopping with that. We are removing the metatarsal head also. Right. We are going with proximal and we are removing the metatarsal head. Why we are doing this means, if we don't remove the metatarsal head, right, we have removed only the phalanges, means The head will be very soft and it will have a oblique convex structure, right? There will be a convex structure. If you take out a head of the femur or a head of the uh, what is this?
Yes.
Head of the femur or head of the humerus, it will be you will have a rounded surface,
Yes, sir.
right? The same will be there in every bone. In every bone there will be the same kind of thing. There will be a rounded thing, which is nothing but the head, right? It is closed.
Yes,
Why
sir.
we are removing that means we are making the growth factors and other healing factors to come out of the bone marrow. As you all people know, the bone marrow is rich in that growth factors and all.
Yes, sir.
Okay. Hello.
Yes, sir.
We are allowing that growth factors and other factors to come out of the bone marrow into the wound to make the healing faster. That is the concept.
Okay, sir. Understood.
Then what is if we do a reamputation means it is a good drainage for the deep spaces of the foot and all. Regarding reamputation of the first and fifth toe, it is very troublesome because of the blood supply lacking. So they should be done carefully. Okay. The main thing regarding reamputation, this is a reamputation. In reamputation, we will use the incision like this only. This is nothing but the tennis racket incision, which will be in shape of a tennis racket, like this. Okay. We will deepen this incision. This is the toes, and the toes will have the phalanges till here. Okay. If you remove the phalanges means it will stop with here and there will be a rounded head of the metatarsal here which we should crush it off and remove it to expose the bone marrow. That is the most important thing. Right.
Yes, sir.
Then the next thing is the Gillies amputation, which is the transmetatarsal amputation, which means we are cutting the metatarsals. In previous, the first one in the terminal science amputation, we removed only the distal part of the distal phalanges. Then we came to the reamputation, which we remove the whole phalanges with the head of the metatarsal. Then now we are doing a Gillies amputation, which is a transmetatarsal. We are cutting the metatarsal proximal to the neck and distal to the base. Okay, and we can close this one, Gillies amputation. We are cutting at this level, proximal to the neck. Cutting this level, we are creating a flap and see here there is an arrow mark. Like this we will close and the end result will be like this. This mark which we showed this is the level of amputation. See here mark in the bone. The metatarsal will be transected. The next one is the Lisfranc amputation. Which is the torso-metatarsal disarticulation. Which means we are removing the metatarsal from the tarsal attachments. Torso-metatarsal joint is broken down. That is what we are doing in a Lisfranc. Then the chopart. Chopart amputation is a disarticulation of talonavicular and calcaneal cuboid joints. The previous one we are removing the metatarsal from the tarsals. Here what we are doing is we are removing the navicular from the talus and the cuboid from the calcaneum. So the talus and calcaneum will be removed. She will be retained with the tibia and fibula. That is the ankle joint. Talus and calcaneum are preserved. The attachments, that is the distal bones from the talus, that is the navicular, and the calcaneum cuboid, both will be removed. That is chopart. Then Symes amputation. Symes amputation is a removal of foot with the calcaneum. The calcaneum is removed. At the ankle joint, we are doing a Symes amputation, which the thing that is retained in the Symes amputation is only the heel flap. What is a heel flap means we are in the ankle joint. If you assume is there will be tibia and fibula above. Other than that, tibia and fibula above. Below that we will have a talus. After that we will have a calcaneum and cuboid and navicular. Right? So the ankle joint, if we do a sinus amputation, means we will remove the entire foot with the calcaneum also. So the tibia, fibula, and the talus will be retained with some soft tissues retained. That soft tissue which we retain is called as heel flap. This is what we are doing in traditional olden days. Then there is the modification of the sinus amputation, which is the boy. And now is not of his exit. The landmark we have is the distal to the peroneal tubercle. There is a peroneal tubercle. We will remove the calcaneum anterior to that, and the posterior part of the calcaneum is retained. Okay. What we do now, the posterior calcaneum will be sutured to the tibia. I will show that right here. See, this is boy's amputation. This one is boy's amputation. This is there mark incision. Amputating only anterior is the posterior thing is retained. Posterior part of the calcaneum is retained here. So what we do is we will make this flap to come and tie here. See, this is what we are doing. We are retaining this posterior part and we are taking this above to close here. Processes can be given for this type of amputation. Man and the patient will have a happy life post amputation. Another modification of sinus amputation is period of amputation. This is nothing but the amputation of foot at the angle, but a part of the calcaneum is preserved as I said in the voice amputation. The calcaneum section vertically, as I said before, anterior part is removed, posterior part of the heel pad is retained and rotated forward upward any degree to meet the distal end of tibia. That's it. The voice amputation, we are cutting the calcaneum at the distal to the peroneal tubercle. Okay, we are not cutting vertically. That is the difference between the boys and Perigoff's modification of the sinus amputation. So,
Yes, sir.
hello. Any questions? Any doubts?
No, sir.
Any others? How many of you are there? Hello. Anyone with any doubt?
No, sir.
Why I can't hear any other voice? Only one person is talking all the time. Okay, whatever let it be. Thank you. Thank you, everyone.
Thank you, sir.
Thank you.
Thank you, sir.